I am obsessive when it comes to therapy, so, but some of this stuff, like allergic, sinusitis, not allergic, fungal. I put it in there, but I am not gonna test it. Some of the more far out therapy, I put it in there because you may start to see it, but I'm not gonna test you of it. So look for those, things on the side.
Well, bless you. We appreciate that. And you know what? That's less we have to say, kid.
Okay, so amoxicillin, again, for most of the diseases that are in this group, it's amoxicillin right back there where we've talked about it with the, almost for the head, since you're dealing with staph and strep, it's usually going to be a penicillin. So I brought amoxicillin back just to talk a little bit more about it. So it is a beta-lactam antibiotic. All the penicillins are. This one's an aminopenicillin, but ampicillin, amoxicillin, all the penicillins, cephalosporins, they are all beta-lactams. So it's referring to how they are structured. So these drugs work by binding to what's called the penicillin binding protein of the bacteria. And those binding proteins are the final step in creating the cell wall around a bacteria. And so these antibiotics disrupt that so that the cell wall will not hold and the bacteria will leak and eventually die. So these cell walls of the organisms that are susceptible, like staph and strep, have these cell walls that are all cross-linked. Okay. So what these antibiotics do is they go in and they make it impossible for those cross-links to adhere to each other. So the cell wall just won't stand up. It would be like the inability to nail the pieces of a fence. You got your fence stakes, you got that one bar that goes across horizontal. It would be the inability to nail those in there together. And so the fence falls apart, the cell wall falls apart. So this is just showing you again just a different version of those critical pieces where the antibiotic just doesn't allow the cell wall to finish. So amoxicillin coverage, we've talked about this. Gram-positives ought to be apparent by now because you've got staph and strep that we talk about all the time. Some anaerobe coverage, some Listeria, Enterococcus, gram-negative limited. When we put the beta-lactamase inhibitor on, then we get even broader coverage. So all those bacteria that can produce beta-lactamases, we can now use them and the organism can't destroy them. So amoxicillin, if you've got somebody who is naive or aversion to antibiotic use, then amoxicillin probably will work. If there's some high risk for a resistant strain, they've been treated in the last 30 days, they have been at a daycare or an area, you have them listed in each of those different situations, then you're going to want to go with amoxicillin and clavulanic acid. So these are the drugs of choice in the bacterial sinusitis for either kids or adults. You've got low dose and high, or standard dose and high dose that are listed in your handout, and the chronic sinusitis, and then an option for bacterial pharyngitis. I am not going to ask you doses. You have to know what the drug of choice is. And also, and they're in your objectives. So what the faculty keep telling me is what they're going to ask you on the boards. I don't like to be so board driven, but I know it's important for you. It's first line, second line, and if there's an allergic reaction or immunocompromised, or sometimes what do you do in pregnant women that's different. So that's, and I've highlighted those in your handout as well. So the cephalosporins are very similar to the penicillins. They were developed to try to add to the problems that the penicillins we were having with penicillins, because as soon as we started using them, the bacteria figured out what to do and those drugs became less useful. So the cephalosporins are gram-positive, gram-negatives. The gram negatives usually increases as you get higher in the generations, and your gram positive usually decreases. They don't have any anaerobic coverage, and they don't cover Enterococcus or Listeria or any of the atypicals. They're usually pretty well tolerated. Both of these are. GI is to some extent the most common, and then hypersensitivity reactions. Here's the generations. I put the ones in blue that we have talked about in class, so that when you see all these, I don't expect you to recognize them, but those that are in blue, you should start to put together with where do they fit, because they come up in our recommendations for treatment over and over and over and over again. So first generation, we don't, like Keflex, like if you get a skin infection like around your nail or a minor cellulitis, Keflex is a common drug we will use because they have still has good activity against bugs on the skin. The second generations, you're going to start picking up the gram negative, so that's where those come in. Here's your third generation. We talked about them a lot, because they end up being the second choices. You can see most of them are IV, so those are going to be your sicker patients and the hospital patients. The one at the bottom that's PO is going to be one you could use on an outpatient basis. Okay, so good strep activity, so that's why we see it in the head, because we're dealing with strep a lot. And better gram negative than we saw with either the first or second generation. But we don't have Pseudomonas coverage. So if we have Pseudomonas, what's usually our drug class to go to? Fluoroquinolones. Okay, good. Oops. I got them out of order. So this is the fourth generation. We only talked about one of them, cefepime, and it comes up occasionally in the recommendations. It has Pseudomonas coverage. It's a very good broad spectrum. It's IV, so this is one you're going to give in the hospital. The fifth generation is only there so that you'll know that there's a fifth generation. We're rarely going to talk about it. So this is kind of the summary slide. So generation, again, tells you about spectrum. As a general rule, as you move up, you're losing gram positive, you're gaining gram negative. The exceptions are the third generations. That's why you see them so often in the recommendations as a second line. And then the fifth generation one, we usually reserve when we have things that are resistant. Cephalosporins don't have much anaerobic activity, so we're going to have to add something onto them whenever we've got an anaerobe or a poly mixture of organisms. Okay, so in the diseases you had today, IM ceftriaxone was listed. It's a good one because you can give it in the office. It's usually a one-time dose. If you've got a kid that's vomiting and can't keep it down, or you've got NPO, it's a good one. Or the sinusitis. We also see it come up when we're talking about the salivary glands or in pharyngitis. So those are the only two antibiotics I covered because they were consistently showing up with almost all the diseases we talked about. Rye syndrome, are you familiar with? So have you ever been told to avoid aspirin? Most of you are just getting over 21, so we usually recommend that you don't use aspirin. There are times to use it, but we just don't use it as a pain reliever in children, infants, or even adolescents because of this problem with Rye syndrome. So when I talked about pain relievers, did I talk to you about aspirin? No, what are the two groups we talked about? Acetaminophen and the NSAIDs, or the ibuprofen. So this is the reason why we don't use aspirin routinely in children is Reye syndrome. So Reye syndrome has been associated mostly with post-viral syndrome in kids that were recovering from the flu or chickenpox. It tends to cause, it is a lethal condition, causes swelling of the brain, the liver. You can see the CNS symptoms listed there. It's very quick in onset, becomes a medical emergency. And aspirin has been linked to Reye syndrome in those situations. Also in kids who have fatty acids storage metabolism, errors of metabolism. But those are uncommon. And so these other two, those viral illnesses. So we don't use aspirin.
What's the mechanism there?
You know, I don't know. I'm not sure what it does. I brought it up because it came up in one of the I highlighted it, so I wanted to go over and cover it. Under pharyngitis. They listed avoid aspirin. So aspirin is a acetylsalicylic acid. So any of the salicylates are, a salicylate is what aspirin is. So any other types of salicylates would fall into that category. Okay, so that's kind of all the drug review. Did you find it?
Oh, no, he's leaving it at. I was
Okay.
talking about something.
Okay. Let's just run down through allergic rhinitis and then oral candidiasis and we'll be done. So symptoms with allergic rhinitis is a very common problem. You'll run into it a lot. Most of the drugs are over the counter now, so people may self-treat and you don't see them until they can't get it under control. So we divide the symptoms into either nasal or non-nasal. So the itchy, the sneezing, the runny nose, the postnasal drip, all of those are nasal, and the others are the itchy eyes, watery eyes, sense of fullness, inability to sleep, ear fullness. Those would go along with non-nasal. We divide treatment along whether does it occur just periodically or does it occur all the time. So intermittent are the symptoms are present less than 4 days a week, or they persist for less than 4 weeks. So this would be like, I only have symptoms in the fall when goldenrod is blooming. I only have this in the summer when grass is being mowed. I only get this when I go to somebody's house who has a cat. Okay, so periodic, they're usually predictable, makes them so that pre-treatment becomes really important. Persistent is they have the symptoms for all the time. More than 4 days a week or more than 4 weeks out of the year. Okay, so severity is mild or moderate severe. So mild means you have those symptoms, but it really doesn't get in your way. Doesn't interfere with your sleep, doesn't really make you sicker, doesn't really make you depressed or that you don't want to do things, that you don't want to eat if you're a kid. Doesn't get in the way of your events of daily living, okay, or task of daily living. Moderate to severe means it interferes with something. So sleep's would be a common one. Or I just can't seem to do my work. I can't study, I can't seem to stay at work all day and keep my focus on it. Those would be the more moderate to severe. Triggers are really important, trying to figure out. Patients probably can tell you, here's when my symptoms get worse, or this is the time of the year when my symptoms occur. The reason I bring it up is that the trigger control will go a long way. If you can help them control the triggers or avoid them, then the amount of drug you have to use is less. So getting them to avoid, or if they're really came from a strong allergic background, or you've got parents or siblings that have lots of allergies, then you might want to send them to an allergist to get them tested. And then immunotherapy can be used. So environmental control, keeping the windows closed, especially during the summer or early spring when pollen counts are high. So when we're already in that time of the year where people want to sleep with their windows open. Well, the big thing right now is red cedar. You can see it when you go by cedar trees. They're just red now instead of green. So the one thing you would encourage them to do is sleep with your windows closed. Don't sleep under a fan, because the fan just stirs up all the dust and stuff that's in the room. And use an air conditioner. And if you have an air conditioner, change the filter at least once a month. Those will help a lot. Roaches, huge problem. In areas where you've got very crowded living conditions, you have apartments where you can't control what other people do around you, or where you just don't have really good clean environment. Roaches are a very immunogenic organism. I don't know how they do it. We'll see it in asthma. If we can control the cockroaches, we can control their asthma to a great extent. So those roaches like to crawl all over you at night. But I've seen a lot of kids come in the emergency room with roaches in their ear. I lived in Texas for a long time, so we saw a lot of roach. Have you pulled roaches out of the ear? Yeah. Yeah. Oh gosh. I knew how much people had gotten used to cockroaches when I lived in Texas. I went to a bridal shower, and this was a very high class, beyond what I should have been at, but very nice bridal shower. And the bride opened up one of the packages, a roach crawled out, and nobody even said anything. Because it was so common. I mean, they were everywhere. They were everywhere. I was rounding with a pediatric team one time, and we went into a room that had been empty, and lying in the bed was a roach about that big, and somebody had hooked up an IV to it. It was dead. They had taken it off the floor and put it in the bed. I had never seen a roach so tedious.
Like, here's my patient. I don't know how to do that.
So controlling damp. So if you get, I have seen this a lot in asthma kids where they're living in a rented place and there has been a leak and no one has addressed it. So mold is huge in areas where it's very damp. So using a dehumidifier, if possible, is important. Controlling the animal dander. Cats are the worst. Dogs are second. So if you can talk to parents about what's going on in the household, in limiting. I know there are some breeds of cats and dogs that produce less. So that might be worth asking if the family's insistent. If they're insistent, then the things you can do is ask them not to have the animal sleep with the child, or keep the animal out of the child's bedroom, because you spend a lot of time in a bedroom. So if you can decrease those triggers when they're sleeping, then sometimes they'll do a whole lot better. Dust is huge when we get to asthma. So keeping dust collectors down out of children's rooms will help. Frequently washing them, especially the blankets or comfort items that children carry around with them, keeping them clean will also help. And pay attention to when those pollen counts are high, and stay home, stay out of or stay indoors, so that you can decrease your exposure. Any question there about environmental? Okay, so medications to treat allergic rhinitis. We walked through all of them, and there's some pictures of them if you're not familiar with them. Oops. So I don't see any reason to go back over those except, let's see. If you can pull up on your handout the third page where it talks about treatment summary for AR, for allergic rhinitis. With mild intermittent, what you want to do is you want to avoid the allergen or you want to prepare for it. So there you could pre-treat before you expose yourself to the allergen, or you have things on hand that you can treat thereafter. The only thing that I would say about about treating yourself before you go and interact with a like a cat, let's say, that causes you trouble breathing wise, is that you can blunt the acute symptoms. It's the prolonged symptoms. It's the delayed ones that you won't prevent, and so they can have reactions after they get back home or into their own environment. So sometimes people will expose themselves longer to a known allergen because they can pre-treat or treat right away, and so they expose themselves longer. So sometimes that causes trouble. So here we're usually using an antihistamine. You'll see that with the kids, it's recommended. Can use the intranasal cromolyn if you're going to be continually exposed, you can do that. Or you can use an intranasal steroid. They'll give you pretty fast relief as well. So this is just symptomatic, periodic treatment. It's the moderate to severe where you're going to be layering in those drugs. And there, intranasal, glucocorticoids are your drug of choice. And then the rest are symptomatic treatment. Questions about that?
So the treatment of mild intermittent AR, you know how it has like kind of a list down here? It says first to avoid the allergen, and the second thing is like, so is that the second line of treatment? That's the first line med?
Usually antihistamines is what they'll use.
For kids?
Yes. You could use an intranasal steroid. Just depends on frequency. And if you know that there is a certain time of the year, again, you can treat just during that time. Okay, let's talk about oral candidiasis. You will see this a lot if you're dealing with an acute a population with a lot of children in it, or if you have asthmatics, because the steroids that we use tend to cause this, antibiotics will cause it. Anything you to disrupt the microbial environment of the mouth will lead to thrush or oral candidiasis. Or you can see it in your immunocompromised patients, your cancer patients, those who've had chemo or radiation, or your HIV patients. Those will all be at-risk populations. So we use two antifungal groups. Nystatin is one, and the azoles or the imidazoles are another group. They both attack the cell wall of the fungus and disrupt it, and that kills it off. So your nystatin is here, and your azoles are attacking or disrupting that sterol production that then is incorporated into the cell wall. Here's your friend, the P450 system rears its ugly head. So that's one of the reasons I wanted to talk about the azoles, is because if you use an antifungal, you have to think in your brain antifungal drug interactions. There's lots of them. Fluconazole is probably is the biggest offender. Let me come back to that and spend a little bit of time. So because they interfere with fungal P450 system, they also tend to interfere with the human P450 system. The 3A4, which is probably most of our drugs get first phase 1 metabolism we talked about a couple of weeks ago, this drug will interfere with them. So anytime you put somebody on like fluconazole, and look at their other drugs and look up and see, is there any big interaction? Especially if you're going to use it more than once. If it's the one-time dose, it's probably not going to cause a problem, but if you have to put them on a 5 to 10 day course, you have to know what else they're on. Okay. So just link that in your brain so that when you hear that, those drugs, a little red flag goes up and you think, gotta look up drug interactions. Or the pharmacy will be calling you, or someone will be calling you and saying, this is a problem. They may ask you to change it, but usually what we can do is just address the other drug down in order to use them together. Because they are very good drugs, they're very effective. Okay, so for mild disease, we're going to use nystatin suspension. So it comes, I have this one so you can see it's a yellow liquid, and they all come with droppers because we're usually dealing with kids most of the time when we use them. And except for infants, we use a swish and swallow technique. So we put it in the mouth and we ask the patient to swish it around and then to swallow it. For infants, you can put it towards their cheeks and you can move it around with your finger to get it to cover all the parts of their mouth. It's usually 4 times a day, so it can be a pain, the nystatin, and it's usually for up to 14 days. It takes a while to get rid of fungus. They don't go as easily as the bacteria do. For adults, you have some other options. You can use nystatin. Sometimes adults don't want to deal with the liquid. It also contains sugar, so if you have to use it a long time, you can cause dental caries. So there are some other options. They're all going to be a lot more expensive. So there's chlorotrimazole, miconazole, fluconazole. Here's that azole. So when you see it, you know you're dealing with an imidazole or an azole derivative. So you've got buccal tablets that you can use. You've got troches, which are, a troche is like a lozenge. They just put it in their mouth and suck on it. The only problem with the chlorotrimazole is it has to be used up to 5 times a day. The fluconazole, a lot of people like because it's once a day, but it has a lot of liver toxicity. So you have to be careful in who you choose to use that drug in. I think this is the last slide. I want to show you some prevention that you can do. We'll talk about this again when we get to asthma. If you've got patients that are using a lot of topical steroids, particularly an inhaler, we do something we call is rinse and spit, and that's what that child is showing you, is once you've used an inhaled steroid, is we want you to take some water in your mouth, rinse it around in your mouth, and spit it out. And that will remove a lot of the deposits of that steroid in their mouth. The other thing we can do, especially if we're using an inhaled steroid, is we can use what we call a spacer device. So when you have a meter, this is getting a little bit ahead, but the principle's the same. When you have an inhaler and you press down on that inhaler, it sends out medicine in a kind of a cone shape. And that medicine has been micronized so that it is small enough to get down into the lungs in this case. But the sizes of the drug are all different sizes and weights. So the heaviest of those products fall out. If you're putting it right in your mouth, the heaviest parts fall in your mouth and stay there. The rest of them get moved on down the respiratory tree. So it's the ones that sit in your mouth that can then can depress or suppress microbial growth in the mouth, and then the fungus takes over. So by using that spacer device, the heavier particles drop out before they ever get to the mouth. And then the smaller particles, by the time you start inhaling it, are not going to, they're going to keep moving on down into your lungs. So that's the 2 ways we can get around is rinse and spit and using a spacer device to deliver the drug. Okay, I think that's it. Do you have questions about studying for the test? I've had a few things come up. You know, if you've looked at it enough or you've thought about it enough, what big concerns you have. The biggest, I'm assuming, is just volume. Okay, so you got to look at the objectives. Okay, and some is to take a very organized approach to it. I'm a fairly logical, methodical person, so look at how I've laid things out. I lay them out to me in a way that is logical to think about it. What organism do I have? What are my available antibiotics? What modifies that? Is there something with the patient that makes me choose something different? What dose do I do, and then how long do I use it? Now, I'm not going to ask you dose, I'm not going to ask you duration.
I have a concern. In each class, we have so many different kind of meds. How do we know? Of course, in some of them, you did mention which to choose over which, but just for instance, if you say use fluoroquinolones, how do you know which one to use amongst that? Is there?
Unless I have directed, well, you can tell by the answers will dictate that. So unless I have told you that there is a preferred quinolone of one over the other, then it's a class effect, okay? So look for those. At your point, I'm going to tell you, you would always choose this one over another. Otherwise, you can hardly do that anymore unless there is a drug that really stands out in a class, because the cost, the insurance, maybe other factors are going to drive that, like patient factors or patient conditions, other concomitant diseases or drugs. Y'all aren't there yet. We're just learning basic tree, basic limbs. We haven't even put leaves on it yet. So look at what I have done. Unless, if there was a major one to choose out of there, I would point it out. Other questions?
So, for example, for the exam, a class like the cephalosporins, do we need to know like each individual drug in that class? Like if you were to give us a question, would like, how do I put this? Would like the answer be the cephalosporins, or is it gonna be like a drug?
It would probably be a class, but I might ask you the generation. If I put it in there, then I would look at that.
Okay.
One thing I do when I study is I look at everything that is similar. I look for patterns. Where's the pattern? And then I learn exceptions. So if you will learn patterns for approaches, then the exceptions it's easier, okay? So look for patterns, commonalities, all of those will help. I only have about 12 to 15 questions. I cannot dig down. I mean, I could ask you very nitty things, but it will be to no end. So it's going to be what's those objectives and what are the big concepts. So if you can ever back away and say, okay, what was she trying to get across here, then you're probably going to come to it. The reason why you have to have so much, I mean, we could very much give you just cookbook, but so much of medicine is context. So if you don't understand the drug in the context, we can teach anybody to do that stuff, okay? So it's context, what's happening with the patient, I was telling a group of students last week, a lot of it's decision points. Okay, usually first decision point is what is going on with the patient, what do I usually use? But where are the decision points? Where are the things, whatever can cause harm or death is usually really important. Okay? So if you give a penicillin to a kid that's got a history of a type 1 hypersensitivity reaction to a penicillin, you've caused great harm. So look at decision points and look at places where harm can occur. Or on its flip side would be where is the most success going to lie. So with antibiotics, a lot of what we do is empiric. We go off what is the most likely cause, what is the most likely drug that's going to produce the effect I want. Because you're not going to send for cultures and sensitivities for most of these things. Unless you keep getting somebody who's coming back or you've admitted them to the hospital, then you will have something to dose off of. But most of your antibiotic use is going to be empiric. Okay.
Do you know if we'll be asked farm questions from our clinical medicine lectures?
I do understand from Professor Collins that there have been questions written like that. I haven't looked at them yet.
So on ones that contradict?
There should be no contraindication. And Professor Fetters told you what? No, she told you for the eye. If whatever I tell you, that's what we're going with.
Like this morning's lecture, she said she always used Augmentin first over amoxicillin, and then on your notes it said that your first line would be amoxicillin. So in that
Okay.
situation, what would be the correct
So
answer?
here's some ways to look at this, because you will hear contradictions all the time. because there are many different ways to do it. What I do and what I come at you with is, here are the recommendations. Here is what is evidence-based, and the majority of the consensus of the majority of providers say, do this. What you're going to hear, and what I will try to do a lot, is tell you, this is what is done, here is what I do. And this is my opinion, but here's what guidelines. So in her practice, she is not wrong, but she has come to that through her own experience, probably people she has, she a PA or a physician?
Yeah.
PA. So in the physicians she has worked with, or the systems that she has been in. That is her opinion, okay? That she should not test opinion, and none of us should. So what we need to teach you is, here is what you should consider first, based on evidence, based on expert opinion. So I will look at those. I'll go over that with Professor Collins.
Most of them are in line. If we came across a farm question on the exam, just to, think, okay, who taught me this information?
Do they designate that in your exams?
We don't know that, but as you're reading the question, you can.
You can kind of
This
tell
is
which
the
ones are
first
farm,
exam where
which
we're
ones are
taking-
packet.
You should, yeah.
Well, like, now this exam, these kind of overlapping information, it's hard,
It'll be
it's gonna be hard to
We're
tell.
gonna be getting principal based.
Okay, so Professor Fetters and I should be in full agreement. When I looked at Berry Hills, I matched mine up. Now, he told you some things in class of what he does. Okay, people should not test over what they do. I mean, that's what they should do. Now, what people will do can be different. He doesn't use diuretics, well, that's what he has chosen not to do, and he has his reasons, but it is within the armamentarium of treatment of that disease. So, I'll look over those farm questions that come from other people. And we will try the best we can to not have them overlap. So if they seem contradictory on the test, you do the best that you can. They come out in the wash. I mean, we'll see it show up in your comments and in the stats. What else? But that is a really good thing to bring up. Is what do you do when people tell you, this is what I do, but you have others, you read it differently. They're telling you through the eyes of their experience. But you have to always be careful, because you're an N of one. So it's good to listen to people's experience and pick up pearls from it, but you always have to go back to is what is recommended, or to understand why they do what they do under their circumstances. Okay, all right. I don't know that I will be here in the building on Friday, but I will be watching for your questions, and I'm turning in practice questions on Wednesday. So, anything else? Y'all have done great. I mean, I've had you usually later in the day. I so appreciate that you try to stay with it, because they're long days and they're very hard, and I'm sure your brains want to fall out by the end. So you're in a very tough curriculum. I try to appreciate that, but you will do fine. You will do fine. These people know what they're doing. I've worked with them for a long time, so you'll get there.
Thank you.
Thank you.
Okay, I will. Good luck on